Okay, so I think that we can start this session. So please take a seat. This is going to be a woman has one session. And so this is a joint session by European Bifurcation Club and Women as One to the My Best Bifurcation Dilemma. This is a case-based session. And it's a pleasure for me to chair this session with Tom Johnson. Joanna, I don't think she's here. I think, that, as you know, there were problems in airport with the flight cancellation. And then we have as a panel Sandra, Zendjebil, hopefully it's correct. Then we have Stefan Harb. Then we have Sashko Nikolov. It's okay. It's correctly pronounced. So the first case is going to be planned two-stent technique after STEMI with a difficult side branch access, when, which, and how, and is going to be presented by Ivana Iveljic.
Thank you for the invitation. It's a really honor to talk here at EBC. And now, after all these DCBs, we will talk about something different and get back a little bit in the past. Okay, my patient is a male. He has 59-year-old. He had inferior STEMI with the chest pain 3 hours before admission. Upon arrival, he was in cardiogenic shock. He was pale. He had shortness of breath. His BP was 80/60, and from his risk factors, he had hypertension, smoking, and obesity. His lifestyle was active, in a good condition, and his ECG showed ST elevation in inferior leads. So, this is the angio. As you can see here, we have an acute occlusion of the prox to mid RCA, and this is after primary PCI of the RCA with the 3.5 the death stent. Okay, on the left side, we have a significant stenosis of the proximal and mid LAD with a Medina 111. That is a plaque that is going all the way from the proximal to the mid LAD and into the diagonal. And this, sorry, can you please give back the video from the, I cannot give back. Can you play the video? Sorry. On the video, you can see it maybe more clear that where the stenosis were. So, what to do now with the bifurcation? When to do the PCI of the bifurcation? We know that if there is a true bifurcation in cardiogenic shock, all those trials showed us that we should not do the PCI of the bifurcation at the same time when we do a STEMI. Because this intervention, we thought it would be difficult and probably will take more time. It won't be just an easy one single stent. So we decided, according to the new guidelines for the acute coronary syndrome, to do the complete revascularization, which is recommended now, either during the index PCI or within the 45 days, but because the patient was in the cardiogenic shock, we decided to do the stage complete revascularization. And the decision was to do it 1 month after the STEMI. And what to do with the technique? Which technique? It is a Medina 111, so shall we do provisional or planned two-stent technique? Is this diagonal an important side branch? Is it larger than 2.0 millimeters? Yes, it is. Is it a difficult approach to the side branch? Yes. And it is a significant osteal disease of the large side branch, and we do not want to lose it. So we decided in advance to do a planned two-stent technique. So which technique? The angle was less than 70%. And on this algorithm by the EBC, we decided to do an inverted Culoe technique. So this is how it went. It was a 7 French radial approach slender, wiring first the most difficult branch, which was a side branch. Here you see this angle again, and we tried to shape the wire for the side branch approach, and it was extremely difficult access because it was an osteal disease, the side branch was angled, and it was calcified lesion. So all of these techniques that you can see here in these pictures did not work. Single band, double band, progressive curve, and it really took some time. So for this kind of extremely angled ostium of the side branch, a hairpin band-shaped wire at about 5 centimeters from the wire tip is a good way to bend the wire and enter the side branch. Of course, if you had a microcatheter, it would be extremely helpful, but we haven't. So this is how it went. Shaped wire is advanced in the distal main branch. Wire then is pulled back and hook-like band of the distal tip engage the side branch. And after engaging, the wire was advanced in side branch, turning counterclockwise. First, after wiring the side branch and then main branch, we did a predilatation of the side branch with the SC balloon 2.5. This was the angio after the predilatation. After that, we did a PCI of the side branch with a 3.0 stent. And with the stent in the side branch, this is at least 6 to 8 millimeters. So POET after PCI of the side branch with the NC 3.5, and the distant balloon marker was at the carina, and we did a high pressure inflation at 24 atmospheres. After that, we did a rewire kiss with 2 short NC balloons and simultaneously deflate. The second pot after kissing with the NC 3.5. Then the PCI of the main branch with the 3.5 stent. After that pot with 4.0. And after rewire through the distal stent strut in side branch, 2-step kiss. First NC 3.0 in the diagonal with high pressure. And then second step NC 3.5 in Alaide and NC 3.0 in D1, both on 12 atmospheres, so lower atmospheres, simultaneously deflate. And this is a final pot with a 4.0 balloon. After that, we did a PCI to the proximal LAD, then stenosis that was proximal, with the 4.0 stent. So this is, as you can see here, the final result. And some take-home messages. The timing of the revascularization of the non-IRA vessel after STEMI during index hospitalization or within 45 days depends on the individual approach for each patient. In most cases of bifurcation, provisional approach is preferable. Case, keep it simple and safe. Disease of the main branch and large and completely ill side branch that we do not want to lose and which supplies a very decent myocardial muscle with blood, often leads to 2-stent technique. Narrow bifurcation angle, osteal disease of the side branch that can mean difficult wire access and concern of the side branch occlusion, no large mismatch between proximal main branch and side branch has led us to choose inverted DK culotte technique. Pot and final kiss is mandatory in 2-stent strategies, and double kiss after first stent and after second stent at technical complexity, but resulting has the potential for very good stent configuration. Thank you.
Okay, so this is clearly open to discussion. I didn't mention, I'm sorry, this is a case competition. So we will have to vote for each case, and then at the end there will be the best case of the session. So there is a question coming from the audience.
Well, so the difficulty actually wiring the diagonal really suggests that you have an angle that's a lot larger than 70 degrees. So I would probably not have used a culotte in this case, but rather a T-stent or a tap or something like that.
Yeah.
Would have been my suggestion, because actually you might have even more than 90 degrees, because it kind of looks like it goes a little bit upwards.
And then downwards. Yes, we were thinking about that. Thank you for that question. Yeah. And also we were thinking about maybe DCB in that side branch, but because of that difficult wiring and everything, we decided for the 2-stent technique.
The lower angle you have, the easier it will be to wire the diagonal obviously.
Obviously, yes. Thank you.
It was perfect solution to start with the diagonal branch first stenting, because afterwards, if you put on the main branch, you probably would have lost the side branch, and you will never
Go back in.
Go back in.
Yes.
Yeah, it's either culotte or something else. Maybe the preferred technique.
Yeah.
It's maybe in this case
The most familiar with this
most
technique,
familiar.
yes, it's vascular.
One question, what about imaging? Because now, you know, we have guidelines and this is one A recommendation. It's a true bifurcation lesion. So which is your practice with the intracoronary imaging? You have limitation to this use, or intentionally you did not use it? Intracoronary imaging.
Unfortunately, I'm working in Bosnia and Herzegovina and we do not have imaging yet. So that is the reason why I haven't used it, yes.
So you saw before there was a QR code. So if we can have the slides, so you can vote using this QR code for each individual presentation, and then we will have the case with more votes. Okay. Any other question?
Yeah. We've just heard a lot about drug-eluting balloon. We have also heard the possibility that we don't decide up front which strategy we want to go for. What do you think about, like in your case, would it have been possible to postpone the decision what to stent and how to stent for after lesion preparation?
Yes, at first that was the plan, but I don't have any more time to talk about it in the presentation. But after, maybe it took me half an hour to put that wire in the side branch. And that is why I was returning to my first plan to do a two-stent technique.
Excuse me. What wire did you use?
Sorry?
Which wire did you use?
I used BMW, then Fielder, then Pilot, and then with the Whisper it was done.
So to wire these lesions, you need a little better tip load.
Yeah.
Plus you need a little better body in the wire. That is how it helps to hook and push.
And as you mentioned also, the use of maybe a dual lumen catheter or microcatheter may have
Yes,
been an
but I
alternative
haven't
approach.
got
No,
it.
I know you've achieved a fantastic result.
Thank you.
Truly.
But even sometimes, if you don't have the microcatheter, you can use the balloon as a guidance to the near the lesion, and after it you can better control the wire inside.
Yes, but the angle was really difficult. I
But the
tried with the small balloon, yes.
Yeah, the balloon
Yeah,
to
yeah,
be.
yes.
You
in
see the
main-
marker, and after the marker you
and
can.
then tried to put it there, but it was really difficult.
Great. Well, thank you.
Thank
Lovely
you.
presentation. I think we'll keep to time. So it's a great pleasure to invite Jolanta Siller-Matula from Austria to present on the sex and gender differences in peri-PCI antithrombotic treatment, a left main bifurcation case. Jolanta.
So thank you very much. Good afternoon. I'm absolutely delighted to share with you a case which I performed at midnight. So it's a lady. She's 76 years of age, and she's presenting to the hospital with shortness of breath. And she has a known atrial fibrillation. At that point, she's in tachycardia. She is treated with NOACs. And of course, the TNT is elevated, and you can't see actually nothing special in the ECG. It's atrial fibrillation, but on the day 3, the troponin are rising. And also the CK, and she has a positive D-dimer, although she is anticoagulated, so there is a CT scan done. There's no PE, and she received a TAVI 2021. In this case, I've done 2023. So she also has a heart failure with mid-range ejection fraction, renal failure. She's obese, has osteoporosis and renal anemia. And there is a coronary angiography done 2021 before the TAVI, and there's just a CT of a small RCA, which is codominant, and I will show you. this is the angiogram 2021. So actually, at the beginning, we also, or the colleagues who were, on call, reviewed this angiogram, and nobody was actually thinking about any new event. So, but a very actually a young doctor called me. It was really midnight, so we're all really tired. That he does not believe it's only atrial fibrillation. So I say, we should do another angio. So let's see. And and after I engaged the guiding catheter, which was really not easy with this accurate neo prosthesis, the patient became, of course, hemodynamically unstable, and you can see it must be a plaque rupture, because I can't believe that during 2 years there is such a disease progression. There was a 30% ostial LAD stenosis during the first angio, but this is a really very big circumflex. So what I did, of course, it was not easy to put the guiding catheter into the ostium, so I used very fast the guiding wire, because I was afraid I will lose, I will disengage, and the patient was treated with edoxaban, so she received the morning dose, and she also received from me during the after the radial puncture, also heparin, and at this time point also aspirin. And I decided very fastly, so what should we do? Because this is actually an acute coronary syndrome. She's unstable. It's a midnight. How should I treat this bifurcation lesion? It's not an elective case. So I decided, the first most important thing for me was to, because it's a huge thrombus burden, you can see this, to have a very potent platelet inhibition. So I started the congrural bolus, and I disengaged the guiding catheter, and after 5 minutes, actually, according to the position paper of the European Society of Cardiology, what to do with anticoagulation in unstable patients and patients with cardiogenic shock, because of course at that time point she has developed a lactate of more than 5, to give a very fast intravenous antiplatelet agents. And indeed there is a data for Cangrelor that it improves the reperfusion and also the rate of the open vessel. And you might ask me why I did not use GP2B3 inhibitors, and the reason is that there is a sex difference in the bleeding risk for those agents. So as you can see that we, in all studies, women received excess doses of GP2-3B inhibitors, especially those who have a renal failure and older patients. And we know that if a woman is over anticoagulated, and this patient receiving edoxaban and heparin, and she's older and she received a TAVI, then if a man is over anticoagulated, the risk of bleeding is not so high as compared to women who are over anticoagulated in the cath lab. And it also was for me a decision to use a Cangrelor, which is independent from the renal function and also does not increase the bleeding risk in the cath lab. And this is the first shot after the Cangrelor bolus. And you can see here, from the movement, of the muscle, that at that time point, the patient was hemodynamically stable. She, of course, received one bolus of noradrenaline at the very beginning when the vessel was closed. So now I had a stable condition. So now I could decide on the bifurcation strategy. And because here in this case, it's a left main vessel. It's it's actually a codominant circumflex. I decided for double kiss crash because I had a very large vessels, plaque rupture. And I did it because it's a technique I use most, and I'm experienced in this technique, and just in 15 minutes with these classical steps and for 0 balloons, I was done, and 5.5 pod and kissing and re-kissing and double kissing and so on. So this was the final result. I was really happy with that. But this is not like over. I think we should not think about, treating lesions in such a situations, but we have to have a plan. So I always calculate for my patients, before giving a final recipe how to anticoagulate and how to do the antiplatelet agents, because normally I would go for the one stent strategy, but not in such a case, with a huge thrombus burden and plaque rupture. And using this very useful tool, this is the Academic Research Consortium High Bleeding Risk Score, when you can weight the, the risk of bleeding against the risk of having an ischemic event. So both were high, but the patient was in this yellow area, which means that her risk of bleeding during the next month was much higher than the risk of ischemic or thrombotic events. That's why I decided for this strategy, just although it was a bifurcation, just going for 1 week of triple antithrombotic therapy. At my institution, I do always test for clopidogrel responsiveness. If I'm going for clopidogrel monotherapy, she was responsive. Just the next 6 months of clopidogrel and edoxaban, I invited her to our outpatient clinic 2 times, and so after 6 months, she said she's having epistaxis, so it was just not a really huge bleedings, and then I decided to just go for edoxaban monotherapy, and I saw her recently after 1.5 years, and she's really doing great, and yes, I was really very lucky to have those tools. So this really matters. What I'm really trying to give you the take-home messages, that in such acute cases, it's a holistic approach. It's not only about stents, but before deciding about bifurcation strategy, it's really important to stabilize the patient, choose the really fast-acting antiplatelet agents, take care to not over-anticoagulate patients, especially ladies in the cath lab, because this is associated with a higher bleeding risk. Femoral access in women is an independent risk factor of mortality because of major bleeding events. We know that in such a case, aggressive treatment in the acute phase is important, but then step down according to the bleeding risk really improves outcome. If we would use those tools and those calculators on a daily basis, we know that 50% of women are at very high bleeding risk, and 30% of men. So there's a sex difference which matters. So thank you very much, and I'm happy to answer any questions you might have.
So thank you, wonderful presentation, and a horribly complicated patient. You've only left us 3 minutes, and I've got loads of questions, but I don't know if there are questions in the audience. If I could explore, so the excess dosing of GPIs in women, what's the driver for that? Bad guesstimating weight, age? What are we doing wrong?
We know that women we are treating in the cath lab completely differ from men we are treating in the cath lab. So women are on average 7 years older. They are diabetics more frequently, and because of that, and because of not treated hypertension, they are having renal failure. And because of the differences in the weight and creatinine clearance, we tend to absolutely overdose them. Even those data I shown are coming from the randomized trials, actually, in which doctors actually should, use those drugs according to the protocol, but we do not.
So my question is, again, regarding the hemodynamic stabilization, maybe, I don't know, the case is done well. It's from when, this case?
It's one and a half year ago. Yes.
1 year ago.
Yeah.
So, I mean, we could have discussed about stabilizing hemodynamically the patient with devices, I mean, with MCS, and that's one question. And the second is, what about imaging?
Absolutely.
What about
Thank you.
imaging
Yeah.
guidance? Because we know, I mean, there are countries where, that's why I ask, there are countries where you don't have access to these technologies, but Austria, I think there is access to the technology. Then I don't know if you have coding, reimbursing, but
Yeah.
this is a left main, I mean, big left main, you implanted 2 stents, now you have a class 1 recommendation, class 1A recommendation, and we had already data that actually showed the benefit.
Thank you so much, Alaide. Really important questions. So actually, if like 5 minutes after I gave the patient the bolus of cangrelor and I had a wire into the circumflex and I disengaged the guiding catheter, because this was probably also the angle, you know, the Stavi device, patients became stable. It was like a wonder. If this would not occur, of course, I would go to the impeller. We have this. But I also had have taken into account the patients who was actually really anticoagulated at this point. Edoxaban plus heparin 5,000. She had an ACT of 390. She was obese. Even with ultrasound guidance, the risk, you know, of bleeding complication due to puncture and impeller is really high. So I had to like wait once again in other. And about imaging, is I could it. I used really maybe 80% imaging, but like it was really during the night. And my point was to do it really very quickly. And if this would be elective case, I would use imaging.
I had a question in my country 1 month ago about which is more incident in myocardial infarction in men or women. And I said up to the climacterium of the women, the higher stage of infarction it has the man. But after the climacterium or in the period where the estrogens go down, we have the higher incidence in women. So the estrogen hormone probably should be considered about the anticoagulation, antiplatelet therapy, and of course, much importance about the antihypertension therapy. So we have to, as a gynecologist, work with the cardiologist.
Absolutely, I can only agree.
We're going to have to move on, I think. I'm sorry. Alaide is doing the work in terms of saying how about imaging with case 1 and case 2, so Fizzah, watch out. But imaging works at night. But actually it's incredibly stressful to consider doing it at midnight. But in a patient with high bleeding risk, where the concerns in terms of the antithrombotic therapy, DK crush in the left main, she could always be brought back in daytime for optimization. That would just be a final comment in terms of the nighttime imaging. But Jolanta, thank you so much.
So we are going to the next case, that in this is a case of acute thrombosis of the left main with e-CPR, and the case is going to be presented from Fizzah Choudry.
Yeah.
I hope it's correct.
Oh, good, okay. So thank you for giving me the opportunity to present at EBC. And my name is Fizzah Choudry. I'm a consultant in intervention at Bart's Heart Centre in London. And my case is a acute thrombotic left main stem PCI with extracorporeal CPR. So it's a 42-year-old gentleman. He had a strong family history of premature coronary disease and all the risk factors for coronary disease. He's a smoker, hypertensive, he's hyperlipidemic. He'd been getting on and off chest pain for about 2 weeks, and then ongoing chest pain, which made him present to the local district hospital, ongoing for about 4 hours. His ECG showed left bundle branch block and some anterior ST elevation, and he had a troponin of 2000. His bedside echo, which I hope you can see, but there is a severe LV systolic dysfunction. Because of ongoing chest pain, he was then transferred, I can see it over here, he was then transferred to the Heart Attack Centre, and on arrival, he was self-ventilating. He appeared slightly pale and mottled. His heart rate was about 100, and his blood pressure was sort of teetering on the edge at about 100/60, and he had ongoing chest pain. So in terms of the Sky shock stage, he was about an A to B, but potentially going at risk of going into further shock. These were his diagnostic pictures. So he has quite diffuse, probably significant coronary disease in the right, but he has this very tight distal left main stem, and likely to be thrombotic with the ongoing chest pain, and may well have transiently occluded that at some point. He's got severe LAD disease, long length as well. So essentially, this is a 42-year-old male who's got an acute thrombotic left main. He's hemodynamically stable at the moment, but at risk of going into shock, and he has ongoing chest pain. So at the time, we had the revascularization options of either emergency PCI or emergency bypass, and it was about 9:30 in the evening, and I got a surgeon into the room who had a discussion, and invariably they always say, well, just get on and go for PCI, given he's got ongoing chest pain and is unstable. So that's exactly what we ended up doing. In terms of the PCI strategy, we've talked about provisional, that lovely word. Whether we go for a 2-stent strategy or whether we go for complete revasc, and somebody's already shown these. We went for provisional. The reason for that is because of, as we know, culprit shock. We know that patients who are in shock and who have multi-vessel PCI don't do any better, and in fact may actually be detrimental going forward. And then, of course, the EBC main 3-year outcome data to show that, in fact, patients who have provisional have less incidence of TLR. So we went for a provisional strategy, and of course then you need to think about vascular access. I already had a right radial lit 6 French sheath in, but the other option was to upgrade that sheath to a 7 French sheath, or to go femoral 6, 7 or 8 French. Of course, at the time, I think the oculostenotic reflex thinks, I'm just going to open this vessel, and actually, let's just get on and do it. I've already got access. So, rightly or wrongly, I carried on with my 6 French right radial approach. And what about LV support? The options, I guess, are no LV support, carry on. Intra-aortic balloon pump, and we know the data is not strong for that. Impeller, we didn't have access to impeller at the time for acute cases. And then the other option is VA ECMO. And of course, for the same reasons that I didn't change my vascular access, I decided to go for no LV support and just get on and see if I can quickly get in and out and open that vessel and get better blood flow. But of course, we should be thinking about LV support, particularly in left main cases, because of the high myocardial jeopardy, because of the LV systolic function when you was down, and of course the ischemia time of putting balloons up in an acute case. And so this was the PCI. So initially I was unable to wire the circumflex, so I put a wire down the LAD and used a small semi-compliant balloon to just get some better flow into the LAD and circumflex, which you can see the flow has improved. And I was then able to wire the circumflex vessel. And there was some imaging, it's not the best trace assists there, but you can see in the LAD, was about a 3 to 3.5 vessel, and the left main was about a 5.0. Unfortunately, at that point, after I'd taken my lovely intravascular images, he started coughing, had agitation, went into pulmonary edema, and a cardiac arrest call was put out. He went into PEA arrest during the intubation and had 2 cycles of CPR. Fortunately, he got ROSC for me to continue, but his blood pressure was very low and required adrenaline boluses, and of course his pH and lactate were markedly abnormal. In that time, though, it gave me a bit of time to fully dilate the left main, gets a bit of better blood flow, and then put a stent in. But unfortunately, at that point, as you can see, there's no flow in the LAD, there's no flow in the circumflex. He had an arrest at that point and had a cycle of CPR. Got Ross back again in time, giving me enough time to put a stent in the LAD, but still he doesn't have flow in the circumflex. recrossed without potting, unfortunately, because of time and just wanted to get some flow down into the circumflex vessel, and managed to use a balloon to open up the stent struts. He did get better flow, which is great, but he had some perfusion VT and then went into PEA and ongoing CPR. So he had about 10 to 12 cycles of CPR, and this was with a mechanical device, and of course I couldn't see anything. At that point, we put out a shock call, and that is what we know in the guidelines we should be able to call in experts at that time to decide what is the best way to go forward. So our shock call at Bart's Heart Centre is interventional cardiologists, intensivists. We have heart failure and transplant specialists on the call as well, and an ECMO consultant. And the decision at that time was to, the patient was in refractory arrest despite the external compression device, and to proceed to VA ECMO or extracorporeal CPR. And actually this was done very swiftly. We had an ECMO consultant on site who came down, and they put in an arterial access with 17 French, a venous access 25 French, and antegrade cannula into the right femoral artery to ensure blood flow into the leg. And an intra-aortic balloon pump, one-to-one augmentation, to ensure that we were able to unload the LV and to improve coronary flow. And in fact, it was so swift, it was completed in 20 minutes. And often we say we don't like to do this because sometimes it can hold up the health stack centre service and the primary PCI service. But in fact, it was done so swiftly, which was excellent. And it allowed me the opportunity to then have another look at the coronaries and see if we can optimise the left main. And these were the pictures just after we'd got the patient back onto extracorporeal support, and managed to complete the procedure with a kissing balloon inflation 4.0 and a 3.0, in fact a 3.0 drug-coated balloon in the circumflex, which initially I inflated sequentially and then did the kissing balloon inflation. This is the pot, 5.0 pot, and then this is the final result. And there is a bit of imaging here as well to hopefully make sure everyone is happy with the final result. So this is the Alaide with which is well opposed and well expanded stent, and the same in the left main. So it was a good result for this patient. So essentially this is a case of a STEMI with left main thrombus, pulmonary edema, cardiogenic shock and refractory arrest. And I hope I've shown you that a rapid initiation of peri-procedural e-CPR can allow for you to complete a successful left main PCI. In this case, it's provisional. We did use an intra-aortic balloon pump to improve blood flow, coronary flow as well, and to unload the ventricle. He did reasonably well post-procedure. Of course, there are often issues with patients on ECMO. He had a post-procedural hemothorax. He went on to hemofiltration, but he was decannulated off VA ECMO at day 10, and he had a 1-month stay in ITU. And in fact, on discharge, which was quite we were very happy with the result, though he was even discharged. He got to discharge. He had a repeat TTE. His ejection fraction was 35%. He's had a primary prevention ICD put in. He's had a successful outcome, and the plan was for symptom-guided management of the right coronary artery, which he has never had symptoms again. And in fact, he came to the heart failure clinic about 3 weeks ago. He's chest pain-free for the last 2 years. This case was done 2 years ago, and his ejection fraction is about 20-25% at the moment. He's doing reasonably well. So that's my case.
Couple of questions in the audience. Lovely case, Fizzah, thank you. We'll just wait for the microphones. I mean, you pay, it's always very sterile, these presentations, but that is a hideously stressful procedure for everyone involved, presumably.
Yes.
So what was your anticoagulation strategy, and why do you think you had no reflow after your first balloon inflation? Do you think you embolized downstream and shut the vessel off? So very important if you had potent anticoagulation, that first thing. And secondly, 3 ECMO trials have shown really no benefit in AMI shock, and really Impella is the way to go. And certainly there was a dysfunction of the left ventricle. I don't know what the EDP was, but that would have given you good direction as to, before inflating the balloon even, to do something in mechanical support before you went in. Because if the EDP was high and you have thrombotic left main, you're going to get in trouble just inflating the balloon. So anticoagulation strategy and, think of a different device because 3 ECMO trials have shown no benefit. The only benefit is danger shock.
Great questions. The answer to the first question is that we gave ticagrelor up front. That's our usual anticoagulation. Well, it was our usual anticoagulation. Now we generally tend to give prasugrel, but at that time we were giving loading of ticagrelor. He was awake, so he could take it, and he had aspirin. When we got him on the table, I did give him integralin, which is our 2B3A of choice in our centre. So we had all of those things on board, and I completely take your point about upfront support in terms of the case, and I think that would have been beneficial. And I think at the time I was very keen to just get something in and open up the arteries, but I think that may have been helpful. Unfortunately, you're limited as to what you can offer in your centre. So a balloon pump, I don't think, could have provided some support, but the evidence for intra-aortic balloon pump is not great either. So I think Impella would have been ideal. If we could have used that, we couldn't because we didn't have access to it. There is some data for it. I mean, this is not even VA ECMO. This is extracorporeal CPR. This is somebody who's in refractory arrest. So there is even less data for that. There is some data within hospital, though. So if patients go onto extracorporeal e-CPR in hospital arrest, not in out-of-hospital arrest, there is some benefit in terms of neurological outcomes. So there is some data. I agree with you that it's not amazing.
I'll just come to your rescue here,
Sorry.
being a danger investigator, that all of the Holger-Thiele trials included patients with cardiac arrest, which leaves quite a lot of space for a type 2 area that is seeing not seeing a biological difference that is there because of mixing of patients with very, very high mortality. So that's one point. The other point I just want to make is that in those cases that you've shown here, we always take the patients back a number of days after to do another angio because it's very, very difficult to appreciate the stent size in the acute settings. And as a matter of fact, I'm impressed that you got so big stents in the arteries because you put in a 3-0 stent in the left main and it looks like enormous when you do that.
Yeah.
So we always take patients back.
So the issue is your patient develops some compromise after the imaging. So why do you think so?
I think there was a lot of thrombus probably that I
Yeah, so
hadn't appreciated.
we've encountered often and we found that the heparin given is less. So when you do imaging, we possibly need a little more heparin.
Okay.
So, number 2, as he mentioned, your stent in the left main looks pretty large. So it's just a 3 mm stent. Possibly your vessels are very badly diseased. So did you stent at high pressures? Because the entire system looks like into spasm. Did you stent at high pressures?
Well, I think he's in shock, and often you do see that those patients have very.
No. When you stented the left
vasoconstricted.
vein to Alaide,
Yes.
did you stent at high pressures? What was your pressure? Because the entire system looks into like as if it's a spasm.
Well, I sent it to the nominal.
Because the patient is in cardiogenic shock. That's normal that there is spasm because there's no flow.
I think the stent was well sized because I actually did do an IVUS.
No, the
Whether
thing
I should have done an IVUS at that point, I'm not sure because he clearly didn't tolerate it. But I think it was well sized and it went up to I went up to normal
when you
pressure.
have a patient cardiogenic shock. You can do diagnosis from the angio that is not A and B. From it was C from the beginning, most probably, no? Because when you have 100 of heart rate, it's a shock patient, and clearly you don't have access. Mostly, if I have this patient, before even doing the angiography, I put an Impella on. It's a really young patient, large ST elevation MI, I put Impella, and then I study the patient, because then you don't have the issue, you are radial, you don't have the femoral, but they don't have it, so, and by the way, regarding SLS shock, actually, this is a subgroup of patients. This is a patient in refractory cardiac arrest. It's a young patient. You have to invest in this patient. Otherwise, and by the way, the patient was discharged. Yeah. So you saved a life. apart from randomized clinical trial. I think that it's a very great case, and any cardiogenic shock case, I would say. But for sake of time, we have to move on. I think so. Thanks to have shared this case. Okay. So, maybe this is a recorded case. They sent me. It's by Judit Andreka, and the case is of a decade crash in cardiogenic shock.
So welcome everybody, my name is Judit. I'm an interventional cardiologist fellow from Graz, Austria, and it's a really pleasure to be invited at EBC, and I'm really sorry that I cannot right now attend it personally, but I stuck at Istanbul airport, so that's why I decided to record our case presentation and share it with you, which is about decay crash in cardiogenic shock. So our patient is an 81-year-old male who has hypertension, hyperlipidemia, and chronic kidney disease. He underwent PCI once in 2011. That time, the right coronary artery was stented, and then later on in 2020, when the proximal LAD was stented. The current presentation was due to severe chest pain, for which he was admitted to the local emergency care department, where our colleague realized that he has an anterior STEMI. But upon evaluation, he went to cardiac arrest, so that's why our colleague started to resuscitate him, and they managed to brought him back within 10 minutes, but he was on high dosages of catecholamines and on respirator, but stable enough for the transport to our cath lab, where upon arrival, he crashed again. So we started to resuscitate him for the second time. His echo showed severely reduced left ventricular ejection fraction with some apical and septal akinesia without any wall abnormalities or mechanical complications. The blood gas was quite acceptable. And here I wanted to show you our flow chart regarding patients with cardiogenic shock or even CPR. How do we decide, usually in our everyday practice, whether to put mechanical circulatory support or not in the patient? As you can see, this patient had an observed cardiac arrest, and everything except his age was fit into the system. So since he was biologically rather in a good position, we decided to move forward with the ECMO implantation. And afterwards, his circulatory problem got a bit more stable, so we could proceed with the diagnostic angiogram, which showed this LAD thrombotic occlusion. And the thrombus was partially protruding towards the left main as well. So according to that, because the right coronary artery was not shown any disease, we proceeded with the PCI of the left system. We put a safety wire towards the circuit. It was a workhorse wire. And then we tried to wire our LAD. But that one seemed to be rather hard. And later on, we realized why was it that? Because with the help of the stent enhancement techniques, we realized that not only the thrombus itself was protruding towards the left main, but these undersized, underexpanded stent as well, which was put in the LAD, in the proximal LAD, with that mindset, let's nail the ostium. But once again, here is the good example. Why is it not a good idea? So this one caused us a real problem. And after several attempts with different wires, and I can tell you it was at least 20 minutes when we managed to get this pilot 50 wire through more or less in a good position. And what did cause us to believe that it's more or less in a good position, that as you can see here, a small balloon could follow the wire path. Afterwards, we really wanted to to see with intravascular imaging as well whether our wire position is good or not, and what can be the cause of this very late stent thrombosis. But unfortunately, the IVUS probe could not follow the wire route, so we decided to upscale our balloon. It's arguable whether it was a good decision or not, but afterwards, we saw that with this 2O balloon, we could really restore the flow in the Alaide, which was a good point. But at the same time, the patient started to deteriorate, and we saw what was the cause. We managed to dislocate the thrombus in the left main towards the circ, which caused there a TIMI2 flow. So we really needed to act fast. We needed to increase the catecholamine levels, and then we needed to think what strategy would be acceptable in this situation where the wiring of the main vessel, the Alaide, was so hard, and then there is a rather large side branch at jeopardy. To that, we had several options. First, to do the TAP technique, which would mean that first we need to optimize the previously implanted Alaide stent with a kissing, which would cause more embolization towards the circ. But afterwards, putting the second stent, a good carina coverage and a good center position would be achieved. What if our wire is not in a good position? What if the wire is under partially the struts? Then in that case, the coverage of the carina would not be complete because we would have crushed the already implanted Alaide stent with our first kissing. So apart from these reasons, there is also the fact that for the final kissing, we need to rewire the Alaide, no matter how the stent struts are standing there, but I think it would be a hard job as well. So that's why the TAP is not the ideal option here, at least in our opinion. The second option was to do a clot, but to that we would need to rewire the circ towards the first struts of this protruding implanted Alaide stent, which also, I must tell, rather a hard job and can cause also a lot of embolism towards the circ. And afterwards, even we do this, we could not entirely be sure that the first wire is in a good position. But if it is, then we could manage to have a good coverage of the carina and saving the circ with the second stent as well. But also, if the first wire into the Alaide is not in a good position and partially under the struts, we are facing with the same problem as by the top, that the carina would not be covered entirely. And also, there is the fact that for the final kissing, the Alaide should be rewired again. So the third option was the DK crash. DK crash, okay, when everybody heard DK crash, okay, it's so much steps, it's so complicated, but in this case, actually, it seemed to be rather appealing. Why? Because we do not need to rewire the main branch at all. It doesn't matter whether we are in a good position of with the first wire or not towards the Alaide, because even if we are crushing the Alaide stent, the third stent after the circ stenting would cover the whole carina. So with one step, we could save the circ, and at the end, we could also optimize the Alaide as well by having a full coverage of the neocarina and without losing the wire position in the Alaide. So that's why our answer to this question was the DK crash. So we implanted a 3.5 stent towards the circ. We did a sequential kissing, and after the circ rewiring and the first kissing, we did an NGO which showed that the circ was saved, the wire position maintained in the Alaide, so we could proceed with the Alaide stenting, which was also a 3.5 stent. And afterwards, with a fourth rewiring and final kissing, this was our final result. So in conclusion, we can say that mechanical circulators support in cardiogenic shock patients is still a controversial topic, but I do believe that in selected cases, it could be beneficial. And the use of DK crush in these situations where the main branch wiring was rather hard, and at the meantime, also a large side branch is at jeopardy, could be a viable option to save this situation. Thank you for your attention. And again, I'm really sorry that I cannot be there, and probably I won't be available neither online because I will be on the flight towards Frankfurt, but I'm really glad that you listened to my presentation, and I hope that still you can have a great discussion. Thank you.
So I think there is no discussion because we cannot pose questions. If we can have the QR code again, because we will announce the winner at the end of the session. So please vote in the meantime for the prior speakers.
If it's possible, we have 2 minutes about small discussion about the case. It's interesting because we can often find a thrombus in this bifurcation, say LAD. What about the thromboaspiration in this case only? I mean, not only start with the thromboaspiration, and after it you can see.
Yeah, I mean, as I understand it, the protrusion of the stent back into the left main meant that instrumentation was very difficult. So, I mean, the key point there, which I fully support Judith with, was a small balloon passed, and often many people would interpret that as the wire being in the right position. Whereas actually, importantly, they recognised that there still was an opportunity that the wire would be abluminal. Yeah, so you can't tell, and you can't tell regardless of stent boost or what have you. Imaging is going to be the only way that you're going to gain clarity in terms of the wire position.
But with the thromboaspiration catheter, you have 3 millimeters that's a rapid that goes on the wire, and after it there's the aspirating part. So you can go further with the aspirating part, and probably you can catch the thrombus in this case. Yeah. And you can, after it, you can stabilize the situation.
It depends on the catheter, because the problem is that they had 2 wires. Not all the thrombus aspirators can leave the wire there, so it depends on the system you have available, most probably. No?
We just have another comment.
I just want to agree with you first, because I think the simple method would be not taking some device, but just pushing in the guide and sucking. If it's a soft thrombus, you get it. If it's tough, you cannot get it. It would have been worth a try, I agree.
Just one remark regarding this presentation, that I think it's, we all know now that there are 3 or 4 papers that you cannot nail the LAD ostium. And now this is where the patient got in trouble, because the initial PCI was not well constructed, and there was probably no imaging, and that's why there was some more protrusion into the left main that caused the problem. And also there was probably an undersized stent. So I think there's two more problems to tackle for this particular patient, and I think the patient's case was solved quite well, because it was very difficult to wire the LAD. Maybe there were some struts that were maybe it was the wire, the initial pilot wire was probably crossing somewhere, which we don't know. So in that particular case, we all know that Judith showed that maybe the only option would be DK culotte or DK crush, so 2 more stents. So I think for this particular patient, having some circulatory support, going with DK crush probably was probably the best option after the initial PCI problems that caused the main problems for this particular patient. That's what I think anyway.
Thank you. Great. Well, certainly some stimulating debate. So I think we have one. I'm conscious of the fact, having just logged on to the QR code, that you can only vote for the best. So without causing an unfair disadvantage to Richa Sharma, I think it's important that that case is presented so that we can then vote for the best of all 5 cases. So triple vessel calcific left main 3 vessel disease in a septuagenarian, tackling the CHIP. Is this another recorded case or? Okay.
Good morning, all. Dear Chairman, thank you for the invitation to present at EBC 2024 meeting. And hereby I'm presenting a case of triple vessel calcific left main TVD in a septuagenarian, tackling the CHIP, how I went ahead. So this was a diabetic 73-year-old gentleman who presented to the OPD with complaints of NYHA class 3 angina since past few months, and had a recent episode of unstable angina for which he was also admitted somewhere outside. Patient was a known case of CAD, had a history of old ACS 9 years back, and at that time his angiogram was done and he was advised CABG, but he refused for the same. 9 years back, he was implanted a dual chamber AICD as well. His echo was suggestive of ischemic cardiomyopathy with an EF of 36% and mild MR. The LA and LV both were dilated. Patient was having a history of orthopnea and PND both. Again, we took the patient for an angiogram because he had an episode of unstable angina. And here we could see that patient had left main disease, a critical left main disease. LAD from ostal proximal to distal was critically diseased. Even the diagonal was having mild disease, but it was a huge diagonal down there. The major diagonal was a big one. Patient circumflex was critical disease. It was a non-dominant vessel with almost 95% ostal proximal disease. OM was normal, and circumflex was having some slow flow because of the criticality of the ostal proximal disease. RCA, we can see that it was mid-RCA was 100% CTO, and grade 2 collaterals were there from LAD to RCA. Patient syntax score was more than 33, and he was again advised for CABG, but he categorically refused for the same. So now, in view of his symptoms of orthopnea, PND, failure, unstable angina again and again, we had to do something for this, and we thought that we will deal with the left main bifurcation in this case. Our plan was to go for rotablation of the LAD and LCX and do a dedicated bifurcation technique in this as per definition criteria. It was a huge circumflex. We cannot leave it just like that. So right femoral axis was taken and a 7 French EBU guide was taken. Both LAD was wired with cyan glue. We tried to cross the IVUS catheter, but it couldn't cross beyond the mid-LAD portion where it was the tightest lesion. So took a microcatheter and parked it in mid-LAD, and cyan was exchanged with the rota wire. Since our IVUS catheter was not also crossing, we took a 1.25 millimeter bud at 180 RPMs and started rotablating the vessel with the same. We did differential cutting as well by rotating the EBU guide. Thereafter, again, rewired the LAD with cyan, and check shot was taken, and there was no dissections or slow flow noted, no perforation was there. We wired circumflex with feeder and exchanged with rotawire over a microcatheter. Again, the same burr of 1.25 millimeter was taken, and in the second shot, we can see that our burr got actually stuck probably because of the tortuosity and very critical lesion and calcific lesion. So at this point, we gently pulled out the assembly, and the burr also got stuck, burr also came out. So by proper hooking of the EBU guide, we again took the same burr and started our rotablation with 1.25 mm burr. L6 was at 180,000 RPMs. There were no dissections or perforations noted in the circumflex, and flow actually got improved after doing the rotablation of both LAD and L6, and we can see in this view. Also in the distal circumflex, flow greatly improved. We took an IVUS run before that, and here we can see that the distal LAD, we could see a concentric 360-degree calcium without any fractures. Coming proximally, there were calcium fractures seen in various planes, multiple fractures. In mid part of the LAD, we can see that again the calcium was pretty not breakable, no fracture seen here. And osteoproximal part, it was more than 270-degree almost. Coming to left main, there were we can see that the area is good in the left main. In the mid part shaft of the left main, it was critical diseased. So now, in view of this, we thought that we will do, again, we will upgrade our burr to 1.5 mm and again do a rotablation and rewired the LAD with rotawire again and ablated it with a 1.5 mm rotaburr. And we can see that in the osteoproximal part, our burr was getting slow also. There was change of sound as well at this point. But ultimately, with a few motions, we could get past across this lesion. And also we did this 1.5 burr at the mid part of the LAD at the tightest point. So this was adequately blurred. After this, this was the IVIS run, and we could see that the distal part of the LAD, it also got fractured. The calcium fracture was seen here. Reverberations were seen here. And then coming proximally, we can see there were multiple fractures in the whole of the LAD. In the ostial part also, fracture was seen now. But still, this portion was not very good. So I thought now I'll have to do a balloon dilatation, balloon bed preparation with a balloon in this portion. This was the left main, which was again showing few fractures and reverberations both. So after this, the rewiring with sand blue was done in LAD and feeder FC in LCX, and bed preparation was done with a 2.5 mm balloon in mid LAD, 3.5 mm proximal ostial proximal LAD, and circumflex was pre-dilated with a 2.75 NC. All were NC balloons. High pressure dilatation was done in all the vessels. After this, it was a dedicated bifurcation stenting with a DK crush. That is my default strategy that I do in left main bifurcation. So keeping a 3.5 mm NC balloon in LAD, took a 2.75 into 24 mm DES into circumflex, keeping minimal struts into left main. LC stent was crushed with the same 3.5 mm balloon at 14 atmospheres. After this, the circumflex was rewired, probably through the distal stent struts. Didn't check it on IVIS, and we did our first kissing balloon inflation with a 3.5 NC in LAD and 2.5 NC in circumflex at 12 to 14 atmosphere. So this was followed by stenting of the LAD, a 2.5 into 28 mm DES in mid to distal LAD, and 3.5 into 30 mm DES from LMCA to LAD was deployed. Diagonal was, we had our diagonal flowing, the huge diagonal, it was flowing pretty well. So we didn't touch that diagonal, and we didn't plan for it also because probably we thought that the ostia was good. There is some pinching, but we didn't do anything for that. We just did a pot later on. So after this, LAD stent was post-dilated, and a pot was also done with the same 2.75 NC balloon display, and coming proximally with a 3.5 balloon, mm balloon with 18 to 22 atmosphere. This was the result that we can see. Circumflex was rewired. First, we did a pot with 4 into 10 mm balloon, and then circumflex was rewired through the LMCA stent struts. So first, we did we opened the struts with a 2 mm balloon, and this was followed by a second kissing balloon inflation with a 2.75 NC into circumflex and 3.5 NC into LAD. This was followed by, we can see that the LAD ostial proximal was still underdilated, and it was the most difficult part that we saw in the IVIS as well. Here we used, I had to post-dilate this portion, otherwise the patient would come with the stent thrombosis or ISR again, and the whole procedure would be of no use. So took an OPN NC here and dilated of 3.5 mm size and dilated at 36 atmosphere. This was followed by a final pot with a 4 into 10 mm NC at 20 atmospheres. This was the final result, in which we can see that all the diagonals were flowing pretty good, and LAD, ostial part of the LAD, circumflex, left main, they were all dilated. And we did an IVIS run from left main to LAD, and we could see that our stents were pretty opposed and expanded all throughout. Patient came to follow up also after that. This case I did almost 3.5 years back. Patient is in follow up and doing well. RCA I didn't touch since patient was asymptomatic. So to conclude, I would just say that a CHIP case is defined by presence of a few features, which includes the presence of calcium, severe tortuosity, bifurcation lesion, high thrombus content, and lastly, diffuse atherosclerotic burden with variable caliber and absence of plaque-free landing zone to facilitate the stent deployment. And in our case, we all had at least 3 of these features: presence of calcium, bifurcation lesion, both in left main and LAD, there were bifurcation lesions, and it was a diffusely atherosclerotic vessel in our case. So we have to actually success depends upon the meticulous preparation of these lesions, and then only we can have a reduced incidence of stent thrombosis or ISRs. So just a take-home message is that calcium assessment, doing a proper bed preparation is extremely important for proper passage of balloon and stents, apposition and expansion of stent, and preventing stent failure rates. The art of rotablating the coronaries is a must for all the interventionists. to win over these rock boulders. Imaging certainly helps to achieve optimal stent expansion, apposition, and measuring the size of the vessel, seeing the plaque-free zone. Imaging actually helps you sail the path in these such cases. And tools for tackling the calcium, like OPNNC, ROTA, IBL, they should be present in the cath labs, and we should have a know-how of how these and where to choose these particular armamentarium. A point to highlight here is the use of MCS device in these high-risk patients, because anything happening in LAD would have resulted in disaster in my case. Fortunately, there was a dual chamber AICD inside. So even if slow flow would have happened into LAD, which is supplying collaterals to our CA, that bradycardia would have been taken care of the dual chamber AICD, which was already present. Complex bifurcation, according to definition criteria, that requires an upfront two-stent strategy. Here we had a difficult, a huge side branch, more than 10 millimeter lesion. So I took a decay crush default strategy in this case. And CHIP cases, they need perseverance, prompt action, and constant assessment of various strategies together. There is something on calcium. We all know this, that where to use which, according to this algorithm, where to use which device for ablating this calcium. Or thank you.
Great. Do we have Dr. Sharma online?
Yes.
Yes.
Hi.
Can you hear us?
Yeah, I can.
Oh, perfect. And we can hear you too. Thank you. I mean, congratulations on a great case. Certainly perseverance. You say that the menace of calcium and perseverance were the two key messages I got there. But your use of imaging to define the modification, I thought, was impressive. Obviously, once you deployed the stent, you then had an ongoing issue with stent under expansion. Did you? I missed. Did you use intravascular lithotripsy? Was shockwave a device used at the time of the procedure?
Sir, IVL was not used here because of the cost constraint. Already we had used balloon and IVUS and the two rotablation catheters, 1.25 and 1.5. So in this part, we have that limitation of, that's why IVL I couldn't use.
Because I would wonder, so certainly from our experience, that rotor shock, combination of rotablation and shockwave is very effective in that concentric calcification. So you did a fantastic job in the absence of that. I congratulate you. Any other questions or comments? No? So thank you.
Thank you very much.
Really great presentation. We're running slightly over time, so we will use this opportunity, maybe just have the QR code up on one further occasion for voting, and then we can give the result. If you just stay online with us, be great. I mean, we've had 5 fantastic cases, and with an array of complexity. I mean, all have had complexity either procedurally or in relationship to the patient presentation with comorbidity and high bleeding risk. I think what's been demonstrated is taking a stepwise approach and a safe approach to the treatment of these highly challenging bifurcation cases. Are you going to show up the final result? Great. So, Fizzah, congratulations. I'm afraid that it's a warm feeling inside rather than a physical prize, but I hope you enjoy it. Congratulations. Very nice case.